Hello and welcome to another episode of Microbially Speaking. I'm your host, Kevin Stinson. If this is your first time joining, then welcome to the channel. If you're a returning listener, then certainly welcome back. So I was away last week, not able to put out an episode. I was on vacation up in Northern Ontario at my family's cabin. And while I did try to record and release something while I was up there, the complete lack of any kind of technology made that slightly prohibitive. So we're picking it up today instead. Now, in a somewhat timely turn of events, while I was up there, my news feed, my social media feeds were pelting me with headlines and about an 11-year-old boy who died after waking up to find a bat on his face at his cottage in Northern Ontario. And so that's the story we're going to look at today. We're going to take some time unpacking this story, talk a little bit about rabies, a very unique and very intriguing virus, and we're going to see what we can take from this incident and pull away in terms of public health messaging. Now, as you read through the articles on this story, if we dive into it, we see that the incident itself is not recent. It took place back in 2024. Now, what brought this to attention now is that the case study for this case was just recently published in the Canadian Medical Association Journal. It was published in late June, and as always, I will link to the link in the description of the video below to that article. It's open access, so you should be able to read it without hitting any kind of a paywall. As the story goes, this 11-year-old boy and his family were up at a cottage in Northern Ontario, and he woke up one night to find a bat sitting on his face. He swatted the bat away. His father caught the bat in a cooking pot and released it. Now, the parents report that the bat appeared to be behaving normally, and the boy didn't have any kind of bites or scratches on his face, so they didn't seek medical attention. 19 days later, the boy now starts to develop right-sided facial numbness, paresthesias, or the kind of tingling and pins and needles sensation, and swelling. So parents took him to an urgent care facility. At that urgent care facility, he was prescribed antivirals for what was presumed to be a herpes simplex virus infection complicated by Bell's palsy. A few days later, he's continuing to worsen. They take him to emerge. Now he's unable to tolerate those oral antiviral drugs because of vomiting and a new symptom, odonophagia. Now, this is an important symptom, and we're going to come back to this a little bit later today when we're talking about the pathophysiology of rabies. It's a really important symptom for rabies virus. But you've likely heard of dysphagia before. Dysphagia refers to difficulty swallowing. Dys meaning difficult, phagia meaning swallowing. Odonophagia is a little bit more of a specific term. Odonophagia specifically means painful swallowing. And like I said, it's a really important symptom in terms of rabies pathophysiology. It's not specific to rabies, but it helps to explain some of the common symptoms that we associate with rabies. Now, at this point, coming back into emerge, physicians are made aware of the exposure or the bat exposure, and they notify public health to look at starting post-exposure vaccinations. But again, patient's discharged with a presumed herpes virus infection with Bell's palsy. He's medically stable at this time. The next morning, he's back in the hospital. This time he's admitted. His symptoms have been rapidly progressing and continue to rapidly progress over the coming days. He develops worsening numbness, slurred speech, fevers, confusion, eventually visual hallucinations. As his neural decline continues, he's intubated and brought down to pediatric ICU. Now physicians are really thinking, okay, rabies is probably a causative agent here. It's certainly not the sole thing on the differential, because there are still other infectious and non-infectious etiologies that can have this presentation. But with that bad exposure, physicians are starting to think, okay, we should really be looking at testing for rabies. Approximately 1 month after waking up with that bat on his face, the boy dies in hospital with lab-confirmed rabies infections. So what exactly happened? Let's try to unpack this here. First, we're going to take a look at the rabies virus itself. Now, rabies is a really unique and pretty intriguing virus. It naturally circulates in wild mammals, predominantly groups like coyotes, raccoons, skunks, dogs, and other kinds of like mid to large predators and scavengers. And it's also very predominant in bats. Now, bats may at one point have been the true natural host of the disease because they tend to be infected with a far milder version of illness or far kind of attenuated disease compared to other mammals. And there's some evidence that they're able to more effectively clear the disease and develop immunity. Now, it's not quite to say that this is a host-adapted virus like we saw with hantavirus and rodents. So recall back to that episode, we talked about how hantaviruses in rodents is an entirely asymptomatic viral infection and causes this idea of viral persistence. And that persistence is what allows it to spread and continue to transmit through a rodent population. Rabies does cause disease in bats. It just tends to be milder in its form. Either way, rabies is well established in wild animals as well. And what we tend to see, and what we do see, is that in animals we see very distinct genetic clades circulating in animal groups. And what I mean by that is there apparently at some point was a jump from bats into raccoons. And then we have continuous transmission within raccoons, and into foxes, and we have continuous transmission within foxes. And what we can then see there is a little bit of genetic host adaptation. And so we can tell when we pull rabies out of an animal or out of a person where this virus came from. It's not that the only time that any mammal, be it a wild animal or a human, becomes infected is from a bat. It can get into other animals and continue circulating in those populations, or it can end up being a spillover from bats into humans or bats into animals. That becomes really useful when trying to piece together where did an infection come from. Animals primarily become infected after being bit by another infected host. And this is why we typically only see it in medium and large predators and scavengers. Animals and mammals like mice or squirrels or rabbits probably can get rabies, but something that's going to bite a mouse isn't likely to bite it and leave it be. It's likely to just kill the mouse. And so it's a lot harder for them to be bit and then infected without dying. Now, excluding the peculiar kind of mild form of disease in bats, humans and other mammals have pretty much an identical response and phased approach to the infection. Once an animal's infected, the virus begins to replicate within the muscle tissues where they're bitten. So if you're bitten on the arm, you initially get some replication in the muscle tissue in the arm. This is the incubation period, and it's largely asymptomatic, minus the actual trauma of being bitten or where you are actually, the actual point of infection. In humans, this incubation period can last anything from a few weeks to months. The average is about 1 to 3 months, but there are even rare cases of incubations lasting years from the exposure point. Now, as the virus replicates, it continues to move through the muscle and eventually enters into the nervous system through the neuromuscular junction. So where a nerve will actually meet and meet up with our muscles. Once it's in the nerve, it starts to travel up the nerves into the spine and then up into the brain. So this is the prodromal phase. As it enters into that nervous system, we hit a prodrome of very, very mild, non-specific symptoms lasting around 2 to 10 days. So these are symptoms that include things like fever, headaches, flu-like illness, and you get that numbness, that tingling, that paresthesias at the site of the infection. Now, as the virus enters the brain, we start to get more rapid progression. We enter what's called the neurologic phase. And this can present different ways. Most cases, so about 80% of cases, be it humans or animals, present with what we call furious rabies. Now, furious rabies, we usually see it described with agitation, excitation, sometimes aggression. You get hallucinations, you get seizures and spasms, and you get extreme sensitivity to pain. Now, this is where we also see that idea of hydrophobia, or fear of water. And many attribute that idea of a fear of water to a rabies infection. But it's not really a psychological fear so much as it's a response to that pain, that painful stimuli on swallowing or even pre-swallowing. And so remember back to this case, and we talked about adenophagia, that painful swallowing, being a really important sign in rabies infections. That's what kind of drives some of that fear of water. It's not so much that you're afraid of water, but that swallowing, that pre-swallowing reflex has a significant pain associated with it. Now, the other 20% of cases develop what we call a paralytic rabies infection, where you, from a point of infection, you start to get muscle weakness and slow paralysis creeping up the body until it finally hits the central nervous system. In either case, in this neurologic phase, we see the virus also exit the brain and spread into the salivary glands. And in the salivary glands, it sheds profusely in saliva. Part of this infection also increases the amount of saliva that's being secreted. And so you get both increased salivation with all of that virus just kind of pouring out, coupled with the fact that you have pain and difficulty swallowing. And so you end up with that other classic sign of rabies, that foaming of the mouth, all of that saliva chock full of virus, and you just can't swallow it back. So it ends up being a frothing, foaming in the mouth. Now, in infections in wild animals, this furious rabies, that agitation, that aggression with all of that virus pouring out of our salivary glands, that is what drives biting and infecting the next host. Rabies is about as close as we can get to zombies in the real world. But of course, rabies was the inspiration of the rage virus in the 28 Days and 28 Weeks Later movie series, with some pretty generous cinematic embellishments. But unlike the zombie movies, or the zombie viruses in movies, the real rabies virus, once you hit that neurological phase, you see very, very rapid decline and pretty much eventual death. This is the really frightening part about rabies. Once symptoms develop, even those early prodromal symptoms, that fever, the headache, the tingling in its sensation, those very, very early non-specific symptoms, once that develops, rabies is almost universally fatal. Every year, there's close to 60,000 reported human cases and human deaths of rabies worldwide, and there's only ever been around 35 documented cases of patients recovering. Often these are with really invasive or really experimental treatments that have really a poor track record of success, but are used as a last-ditch effort because there's simply no other options. Once you develop symptoms, it is almost invariably fatal. And so when we think of what is a rabies strategy, it falls largely to prevention. Now, there are effective rabies vaccines, both for humans and for animals, and they do protect from infection and can help attenuate severity of disease if you do become infected. They're not very long lasting. It's certainly not a lifelong immunization. It's something that requires frequent boosting, as anyone who has a dog or a cat at home knows they usually have to bring them in every year for their rabies vaccine. So you might then ask, why would we not just make it a routine part of childhood immunizations if we have a vaccine available? And there's a few different parts to that question. The first part of an answer is that rabies is still exceptionally rare. This 2024 case represents only the first case of rabies since 1967 in humans in Ontario. And since 1924 across all of Canada, there's been only 28 human cases. And so while we see a lot of cases globally, we're not seeing a lot of burden in North America. A lot of this is due to the fact that our efforts on rabies control focus instead on an idea of source control. That is to say, how do we reduce the burden in nature? And if we can reduce that burden, how that will then reduce the risk of exposure to humans. Now, Canada and US both employ very similar strategies here. The idea is to target both wildlife and pet populations to reduce the risk of them acquiring rabies, thus reducing the risk of us getting it from them. Many jurisdictions have mandatory registrations of pets and annual rabies vaccination programs and boosting programs. And the idea there is if those are the pets that humans are most likely interacting with, or at least the pets that can likely acquire rabies without getting killed that we're likely interacting with, then it reduces dramatically our likelihood of getting bit and transmitted to. Now, on the wildlife front, surveillance testing becomes key. It's a lot harder to sit there and find every single wild animal across Canada, across the United States, and vaccinate them proactively. So what we do instead is we look at trying to find endemic pockets of the virus in the population. So we look at capturing sick or finding dead animals and testing them for rabies. Once we find pockets of transmission, then we can employ vaccination programs. So we either do trap, vaccinate, release programs for very targeted interventions to specific animals in an area, or large vaccine bait drops where you get a vaccine in a little edible bait pod and it gets dropped by a helicopter. An animal will come along, eat the vaccine, and become vaccinated. This is what actually drives, and we can see the impact of this, and what drives rabies vaccine cases in North America compared to middle and low income countries or other countries where these kinds of programs aren't in place. What I mean by that is, if we look at Central America, South America, Africa, Asia, Eastern Europe, these areas where we don't have these big programs in effect, we see that the majority of cases of human rabies comes from dogs. And this is also partially driven by the fact that in a lot of these countries, you have large populations of dogs running wild. And they have very close interactions with people. They're not being vaccinated, they're close interacting with people. And so that becomes a natural risk factor for driving rabies transmission. In North America, we don't have that. So we have effective pet control programs, we have wildlife control programs, and we have just simply a different dynamic of how do we interact with dogs, and do we have this kind of population of wild dogs running around cities. And so in North America, wildlife is where we see the majority of human cases, with bats being by far the most common source of human infections. Some Western European countries, and I think even Australia, are completely rabies-free. Their programs have been able to eradicate it from both wildlife and domestic populations, and they have no naturally circulating rabies. Now, all of this is to say that when we think of a vaccine program, there isn't enough risk, especially in North America, to justify going out and vaccinating every single person. Instead, our vaccine program looks at how do we vaccinate those who are at highest risk of exposure. So those who have an occupational, or because of the nature of their work, they are likely to be exposed to rabies. I used to work in a veterinary microbiology lab, and in that work, we used to do diagnostic and surveillance testing from animals, both wildlife as well as pets, to look for causes of infectious disease. And one of the things that we would do is anytime there was wildlife that was found deceased, we would often collect tissues on these animals and do testing to see what was the cause of death. And so to touch and handle those tissues, I had to go through a rabies vaccination series. And so I had a 3-dose rabies vaccine. And let me tell you, and this is probably a slightly subjective statement, but the rabies vaccine is not pleasant. I'm relatively certain I hallucinated after my 2nd dose, and everyone I've spoken to who's ever gotten a rabies vaccine series says that it is one of the worst side effects of any vaccine they've ever taken. And so to take that and expand it out on a large scale just really isn't that feasible. So what does this mean? Does this mean that if you're bitten from an infected animal, it's just immediately game over? No. We have great post-exposure prophylaxis protocols, and there's a fantastic success record with these protocols if they are administered prior to the onset of symptoms, and the earlier the better. So the way that this post-exposure prophylaxis works is first at the site of a bite. We start by infusing anti-rabies antibodies. You take a syringe, take a needle, and you go to the wound and you just start injecting into the tissue all the way around the wound these antibodies to bind up and neutralize the virus. From there, we'll then start a rabies vaccination series on a patient. And if they're previously vaccinated, we'll go ahead and do a booster. Even if they have evidence of infection or evidence of immunity, we will still give a booster anyway to help ensure they're not going to develop infection. So let's take all of this information we've just gone over and look again at this case at hand. What can we learn from this case? Now, first off, it'd be very easy, but probably unfair to use 20/20 hindsight, look at the case and say the doctors missed something. And to kind of elaborate on this, it'd be unfair because early rabies is extremely non-specific. There are a large number of possible etiologies that can cause these non-specific symptoms. And at least by all accounts in the paper, it's not exactly clear if it was disclosed that there was a bat exposure until the second or third trip to the doctors. Unfortunately, even on that very first visit, symptoms had already started. And so even if we had very, very rapidly identified, yes, this is probably rabies and started actions then, it's hard to say if that would have had any alteration on the outcome. Unfortunately, the sole intervention that we could look at that would have saved this boy would have been immediate post-exposure prophylaxis at the time of the bat exposure. But it's not fair to sit there and say, well, then let's fault the parents. Because as the paper says, there was no visible bites or any kind of marks on the kid's face. So the parents likely looked at this and said, well, that was a near miss, kid's fine, that's good, there's no risk here. And honestly, as someone who grew up going to a camp in Northern Ontario, I'm actually not sure if I woke up with a bat on my face, if my parents would have thought to bring me to the hospital or to the doctor if I didn't have any bite marks. Now, in saying that, I'm sure if my mother ever watches this video, I'm going to get a phone call immediately with her challenging that assumption, but we're going to let it stand. The thing with bats are tricky. Bats are a tricky beast to work with. Like we said, they show a milder infection, so they don't always have that kind of erratic behavior that we think of a rabid dog having. The other thing that makes them difficult is that their teeth and their claws are very, very small and razor sharp. It is easy for them to breach skin without any kind of signs or marks or evidence of injury. And in Ontario, around 5% of bats are positive for rabies. So that means that the risk from rabies from a bat, just casually contacting a bat, even without it biting you, is not negligible. In older hospitals where we have bat incursions as an issue, infection control programs usually have some kind of bat and rabies prevention strategy in place. So if a bat is ever found flying around a patient's room and that patient is sleeping, is unconscious, they have an altered mental status, or they cannot definitively, reliably state that they did not contact the bat, it's just assumed that they've been exposed to rabies and the patient has started with their post-exposure prophylaxis, even in the absence of a visible bite. So what can we take away from this case? This case should be looked at as a cautionary tale. And our takeaway really should be to underscore the importance of immediate medical care for anyone who's bit by a wild animal or who comes into direct contact with a bat. And that's even if there's no evidence of that bat having bitten or scratched or breached the skin. By sharing that knowledge, this is a way that we can at least honor this boy's story and this boy's memory. So on that note, let's leave it there for today. Thanks so much for joining and watching. If you enjoyed this, please hit the like button and subscribe to the channel so you don't miss out on future videos on microbiology topics. If there is a topic you want to hear more about, or if you have any questions on today's video, throw a comment in the comment section down below. Love to hear from you. Thanks again for watching, and we'll see you next time on Microbially Speaking. Bye now.